This program is brought to you by Emory University.
Good morning, everybody. Welcome to Friday Morning Fellows Conference. Our speaker this morning's Nikolay Bogush. Nick is a first-year clinical fellow, but a fourth-year fellow. He did 3 years of research with us. He was enjoying his research so much, he stayed and wanted to do a third year in the basic science track. Like I said, he's in his first year of clinical training and looks like he's going to talk today about regeneration. So Dr. Bogush, take it away.
So good morning, everybody, and thank you so much for joining us this morning on March 12th. So today I'll be talking about cardiac regeneration, and my talk is called "Can We Regenerate a Broken Heart?" And just to clarify, it was brought to my attention that broken heart, some people associate that with Takatsubos. And I don't mean that particularly. I mean really any cardiomyopathy that's with reduced ejection fraction with loss of cardiomyocytes. So why is this an important topic to talk about? As we know, this is just kind of like a summary that the leading cause of death in the United States and all over the world is cardiovascular disease due to MI, myocarditis, and all types of other forms of injuries that lead to cardiac injury with a loss of cardiomyocytes, and that predispose and increase risk of heart failure and subsequent death. So it's a disease that affects everybody, not only the patient, but their family members. It's a disease that impacts the economic toll on the family. It impacts the toll on the caregivers for the patient. And also it's a big emotional toll on the patient themselves, where a lot of studies have shown that patients with heart failure are at increased risk for having depression, anxiety, and other mental health disorders, which will lead to further stress on the family and them as well. So what is the current treatment for heart failure that we have? Again, this is just a basic review that we all have known and been doing for many, many years now, is that our current treatment focuses on preventing progression of disease. So we use beta blockers, ACE, ARBs, or Entresto, mineralocorticoid receptor antagonist, the SGLT2 inhibitors, which is the newest class added, and diuretics and defibrillators. But all these therapies have one thing in common. They don't actually treat the loss of myocardium or the loss of cardiac function. All they do is essentially put a Band-Aid on the wound and hope to stop the bleeding without actually treating the underlying wound. So in 2001, there was a revolutionary new treatment that came out, and it gave people a lot of hope that we could be at the cusp of treating heart failure and all forms of heart failure, whether it's ischemic or non-ischemic. And what I first want to talk about today is really stem cell therapy. So in early 2000s, there was a paper that came out looking at stem cells, and the idea was, well, stem cells are cells that are very undifferentiated, and if we put them in an area where there's death or dying cardiomyocytes, maybe they could be regeneration. So the first trial came out around 2001 that looked at mice, and they actually injected mice hearts after MIs with stem cells, specifically progenitor stem cells from the bone marrow. And they noted there's an increase in cardiac functions, particularly EF. So based on that study, there's a lot of hype, and there was a lot of articles published around 2000s where, well, can stem cell therapy be the treatment that ends heart failure? And here I have a diagram which represents exactly what was done. So in this particular case, you can see a syringe filled with cells. Here, the syringe is filled with cells, and it's injected right directly into the myocardium, where the area of infarct was, as you can see here. But this is not the only technique. There's also other techniques which were developed where they injected the stem cells directly into the coronary artery that was causing the coronary artery that was occluded during the infarct. And the hope was to let the stem cells go to the area of injury and be able to replicate. So early 2001 was the first trial that came out looking at humans and injection of stem cell transplants. And the trial was called TopCare AMI trial. It was a very limited trial with only 20 patients, which had acute MI, specifically STEMI, that were perfused within, I believe it was 48 hours. They had a lot of testing done, as you could see here, based on this chart. They had stress echocardiography, they have coronary flow reserve done, and PET, and all those tests were really done just to see, is there any hibernating myocardium there? Is there any reserve in function? And is there any chance that some of the myocardium could be salvaged or improved with increased cardiomyocyte proliferation? And then 4 months later is when they repeated all those tests and did echocardiography, and they wanted to look at, well, what exactly were the results and to see, is there any improvement of benefit specifically in humans? So the first results that they want to show, which was very optimistic, and which gave a lot of credit to this, and they're like, well, this could potentially be revolutionary. As you can see, the ejection fraction from baseline to follow-up increased by 9% approximately, with a significant p-value. And also, when you look at the end systolic volume, which is at the bottom, we can see that it also statistically significantly improved, which kind of goes hand in hand with contractility. So the EF improved, the end systolic volume improved as well. And here, for the second, we have what happened with the control group. So the baseline group, but the control group was really just standard of care, giving beta blocker, ACEs and ARBs, and what the standard of care was in 2001. And you can see the ejection fraction didn't really change. The end diastolic volume didn't really change. And the end systolic volume didn't change as well. So based on this trial, there's a lot of hope that this is, with better technology and improvement in cell therapy, we could potentially cure heart disease. So the next trial that was done was Transcoronic transplantation of progenitor cells. This was a study that really was done to show that it's not efficacy, but more so safety. So the first pilot trial was phase 1. They did a limited amount of people, only 17, and just really that wasn't they looking for efficacy. They were looking for safety. Can we give bone marrow stem cells or bone marrow progenitor cells and have good outcomes, or at least not have adverse outcomes? Because this is a very high risk population, as you could imagine. These are patients with heart failure, with depressed ejection fractions, with scars, at increased risk for VTs and other arrhythmias. So adding a progenitor stem cell or a cell that's not differentiated could potentially lead to arrhythmias and other problems. So the phase 1 trial was done and actually showed reasonable results. So a phase 2 trial was done with more patients. So the phase 2 trial included 75 patients, and they were assigned to CPC, which is circulating progenitor cells. So essentially, is where did you get your cells? Was it from the bone marrow, whether you went in directly and just harvested it, like a bone marrow biopsy, or was it that you gave certain drugs to help release stem cells or progenitor cells into the circulation and extracted it from there? And this was a crossover study. So as you can see, the initial group that got the bone marrow stem cells or the circulating progenitor cells, or the control group, were later randomized to getting the other crossover phase as well. And again, the second part of the study was now really looking for the clinical outcomes and the improvement in ejection fraction and function of the heart on echocardiogram. So here's results for the trial, which did show that there was improved EFs, particularly in the bone marrow stem cell group, where the EF went from 41 to 43%. But I do want you to really take a look at the numbers and really see the improvement was really marginal. It was really just 2% on EF. And the patient and the people and providers who've been reading echoes know that 2% difference on EF is really subjective, within the realm of the subjective quantification. It's not that it was really that significant in terms of just overall absolute value, but it was statistically significant, which again gave people some hope. But at this point, since this is already 4 years later, this is 4 years of trials, and the most benefit they could show is 2% increase in ejection fraction. With the control group, and again, in the circulating progenitor cells, didn't show really much benefit, at least nothing statistically significant. And the second thing that was shown to be, that I thought was interesting, is they looked at the wedge pressure, or the LVEDP, because both of these quantifications were done based on the left ventricular angiograms. So the LVEDP, or the wedge, so something we usually look for to see how much pulmonary edema you have, didn't actually change. So even though there was a marginal increase in ejection fraction, which was significant, that at the end of the day, the wedge pressure, which is the pressure we think about when you think of patients having symptoms, wasn't really changed that much between the two groups, and it was not statistically significant. So what about clinical outcomes? The first trial I showed you really was about the echocardiography and ejection fraction structural changes, really. So what happened with the clinical outcomes? Because at the end of the day, what we're trying to do is treat patients, prevent rehospitalizations, prevent progression, and obviously prevent death. So looking at the clinical outcomes, doing the in-hospital events between the control groups and the stem cell therapy groups between the bone marrow and the circulating, there's really no difference between the death, MI, infarct size or cerebral infarction or arrhythmias between the two different groups, between the control and bone marrow. With the cumulative, you can see the cumulative total, the p-value is 0.2, so which wasn't significant, which did kind of go hand in hand with what we talked about before in the phase 1 trial, the previous trial, that it's relatively safe. So giving the progenitor stem cells did not increase the patients to any really adverse outcomes, but it did not, at least procedure, it did not increase adverse outcomes. Now, what about the long term once the patients go home? This is what I think what people were mostly interested in, to see, well, what happens after the discharge? Is there a decrease in death, hospitalizations, or recurrent infarcts or CVAs? And unfortunately, this study didn't really show any difference. As you could see, based on the cumulative total for events after discharge, the control group had 9 versus the bone marrow transplant group, and the circulating progenitor stem cell group both had 15 and 11 percent, which is equivalent to 5 events and 4 events respectively, without a really big significant change. And the cumulative events before and after discharge were also not significant between groups. So this was a bigger study, including 75 patients now, and this is 4 years later, and there's still not really any benefit, which this is a time where there's a lot of literature is coming out to see, well, maybe we were wrong about this, and maybe this is not as big or as influential as we thought it was going to be. But before they were giving up, we had one really big trial done called Chart-1. It was a European trial done, I believe, in Britain. I'm not sure exactly which country it was done, but it was several countries, which had 315 patients, which were allocated to one, optimal medical management, plus cardiac stem cell treatment, or just controls, which is just the standard of care with medications. And here's a breakdown of what exactly happened with all the patients. But overall, we had 120 patients who got the stem cell, the bone marrow cardiopoietic cell transplants, and we got 151 which just underwent control, which is regular medical therapy. So here, I want to show you the results. So this was results of looking at the primary efficacy endpoint with a Frankenstein-Snellfield hierarchical composite. So this looks like various endpoints together to really try to increase the power and trying to increase the sensitivity of a test to see if there actually is a beneficial effect. So this was looking at the outcomes of all-cause mortality, worsening heart failure, Minnesota Living Heart Score questionnaire, 6-minute walking distance, left ventricle end systolic volume, and ejection fraction at 39 weeks. So this was really a long-term study. As you could see, between the overall population, there was really no difference because the confidence interval goes on to the 0.5. But when you did look at patients with a very dilated LV, with an LV-EDV of about 200 to 370 milliliters, there was a suggestion of slight improvement in clinical outcomes. So again, this is another trial which showed some potential benefit, but there was nothing really concrete, nothing what we've all been really hoping for. And for this trial, there's also clinical events, which again were markedly really not different between 2 different groups, between the sham or the controls and the cardiopoietic stem cells. One thing I do want to note, though, is that these trials, so the only complications that really occurred was really due to the procedure. So a lot of the times, all these trials really included doing a catheterization with guiding a therapy, or at least a catheter, to the infarcted artery and injecting stem cells. So really the only complication that arose from this therapy is the complication related to catheterizations. So it was really based on the center and how experienced the center was at performing left heart catheterizations. There was no really complications from the stem cell therapy. It was all procedural related and related to the delivery of the stem cells to the area of infarct, whether it's through injection or the coronary artery. And again, here you could see the overall complication rates were similar between both groups, and they were not really significant. So let's fast forward to today. There's been many, many trials done, and for the scope of this discussion, I think I just wanted to kind of give you a summary of like all the trials that were done that showed some benefit and the ones that didn't. So here I just want to show you a list of all the trials that were done using stem cell transplantation and their overall benefit. So you can see on the right-hand side, the column I highlighted the red, which is the absolute difference or improvement in ejection fraction that was seen with each corresponding trial. So you can see the range goes from about 2% increase in EF to the highest, which is 15. The 15 was done in only 18 patients, so there's very little it's not very generalizable just because of the little scope of patients that was done. But the bigger trials, which had like 3,000 patients and 1,500 patients, really showed the improved injection fraction of 5 to 8%, which is, again, from the clinical perspective, is probably not that significant. And I don't know if we will be able to see much improvement in heart function just based off of EF increase by 5%, which again falls within the realm of just subjective interpretation. And then this is the studies that came out that were probably more skewed to be more the recent side, which showed there's really no difference in the change in the left ventricular ejection fraction. And this is also, they didn't even bother looking at the clinical outcomes because, again, no trial really showed good clinical outcome data for use of stem cell therapy to kind of regenerate the heart. So by now, really, the overall conclusion based for stem cell therapy is that there's really minimal or unsustained benefit on heart function from bone marrow cells. So the question becomes, so, well, maybe we're not doing a good job of picking the right cells, or maybe the cells are just not incorporating into the area we want to. So the next area was really trying to see, well, where do the stem cells go when we inject them? Do they go where we want to? And what happens? So the minimal improvement in heart function we do see, well, is it from the injected cells, or it could be something else that we're missing that we could further explore? So here, this was a study that I was looking at, particularly just when we inject stem cells. So these stem cells were actually labeled with green fluorescent protein, as you could see, one as image C. You can see they just light up green, so you could identify them easier. This was a study looking at mice, particularly. And the findings were really quite stark, showing that approximately 90% of cells that were injected were lost due to circulation, leaked, or squeezed out from injection site. So it's 90% of the cells you inject are gone within probably the first few hours of the procedure. And the cells that do remain, majority of them end up dying within the first week after injection. And here you could see just the A, B, and C. You could just see where the cells go and how they're really sporadically spread out without really any organization. And the other thing you could really derive from this is that you could see most of these clusters just have one cell. So the cell's not really dividing. So our big hope that these stem cells, which are undifferentiated, would go to these areas of injury and actually proliferate does not actually come to fruition here. So the next question is, well, how did the stem cell injection improve outcomes, right? I showed you a big list of about 15 to 20 studies that showed there was some marginal, statistically significant improving cardiac function. So based on this, there was a new hypothesis formed from that, is that, well, maybe the stem cells that we inject, they don't get incorporated, but maybe the benefit is actually from maybe some kind of paracrine signal, where the stem cells that are there, they secrete some kind of beneficial chemicals or hormones or proteins that help the existing myocardium survive better. So that's the hypothesis that was created, which is the paracrine hypothesis, to kind of reconcile the findings of these control trials that showed some benefit. That, well, the murine trial showed benefit with stem cell injections, while the human trials didn't really show much clinical benefit, but did show some structural benefit. So from this, there's actually a study that came out in 2019, I believe, where actually was able to identify the benefit from stem cells actually stems from the immune activation from the injection site. So this was actually a very interesting experiment where they took mice at birth. As you can see here, they took mice at birth. And at 8 weeks, they did ischemia and reperfusion surgery. So the surgery essentially is supposed to mimic what happens with adults with STEMIs. So they do a thoracotomy, they ligate the LAD artery for 40 to 80 minutes, depending on the protocol. And then they open up the artery again and allow reperfusion to simulate a STEMI situation. Then at 9 weeks, they injected either saline. So this was sham. The first column was sham, so they didn't do anything. They didn't do ligation. They just do a thoracotomy without actually ligating anything. They either injected saline, which is a second group. The MNC, just bone marrow progenitor cells. The fourth group, which I thought was very interesting, they actually took the bone marrow progenitor cells, they froze them and then thawed them multiple times, which caused cell cycle lysis. So all it essentially did is all the intracellular content, the cell membranes were destroyed, and all the intracellular content was just spilled out essentially to the solution, and they ejected that. So for the last group, it's really, there's no living stem cell, there's no cells that are alive anymore. It's really just intracellular content. And then they measured fractional shortening, which is FS, which is a surrogate for ejection fraction that is usually used in mice. And you can see the sham, the fraction shortening was normal, which is expected because the coronary artery was never ligated. But looking at the saline injection, you can see that the fraction shortening had a dramatic decrease. But then when we looked at the stem cell therapy, we could see that the fraction shortening was actually improved with p-values statistically significant. But then when we looked at the stem cells which were lysed, and the only thing that was injected was intracellular content, again, there was marked improvement. So it's not really the cells that were helping, it's really just having an injection of intracellular content that helped. So based on this, their hypothesis was, well, could this benefit be maybe from immune activation? Because what happens when you inject intracellular content into into any area of the body, it's usually you get inflammation. So they actually repeated the study where they did IR surgery, but this time they gave cyclosporin specifically to inhibit the immune system. As you can see now, with the sham fraction shortening stayed the same, the mononuclear cell injection and the saline actually their benefit was blunted now. So now, even though you injected the same thing, there was no improvement in fraction shortening or ejection fraction. Then they further went into they found that specific activation of macrophages at the site of injection induced an immune response, which improved cardiac remodeling and which led to the improvement in ejection fraction or fraction shortening. And the specific cardiomyocyte specific macrophages they found was CCR2 and CXC3R1. And they actually did further studies where when they specifically inhibited those two type of macrophages, there was no more beneficial response from injecting any type of cell or intracellular content. So really one of the things that is being developed right now is this paracrine signaling pathway. This pathway is being used to develop various methods of trying to induce cardiomyocytes to divide, and also for angiogenesis. So the area of fibrosis, to see if we could get more blood flow there, and potentially if there is some myocardium or if there is some cells which are still alive, to see if we could restore function and maybe some amount of replication. So this is kind of a summary of what's currently being developed. So there's cell-based therapies, which again is injection of certain different types of cells to see if there's any beneficial effect, and also to see if some of these cells could induce some amount of replication within the cardiomyocytes or could replicate themselves. And in some cases, we actually now also get adipose tissue or bone marrow tissue, and we try to differentiate them into various versions of cardiomyocytes or the progenitor cells to see is there maybe a difference between cell type usage to see if we could have improvement in function. And one of the other ones being developed is cell-free therapies, where we use genes, where we actually have viruses in viruses which have certain genes in them that we want to overexpress. And with that, we want to see, well, if we overexpress certain genes, can we get the cardiomyocytes either A, to divide, or B, to become more resistant to apoptosis at times of stress? And this is being done with mRNA and various compounds that are currently being developed. So with this in mind, this is when I started my fellowship. There's this big challenge of trying to really take bench-side research and try to apply it to human studies, and particularly for heart regeneration. So I wanted to look at a different perspective. Instead of trying to put cells in there or put any material in there and help cells divide or live longer, can we identify how and why do the cardiomyocytes exit the cell cycle? Because obviously cardiomyocytes divide when we are growing neonatally, so they must have some potential to replicate. So I wanted to really identify what causes them to lose the ability to replicate, and then to see, well, if we remove that block which prevents them from dividing, can we enable replication, and can we enable cardiomyocyte regeneration? So the first question I wanted to find out was, well, do mature cardiomyocytes divide? And the number one the target I was looking for is, in humans, do cardiomyocytes divide after we are born? So there was an interesting study that came out, and actually in Japan, that will use carbon-14. So let me just give you a summary to explain. So with cosmic radiation or any source of radiation, when the neutrons or high energy particles hit nitrogen, it causes an ejection of a proton, which makes carbon-14, which essentially is a carbon that has an extra neutron, but lost a proton. And then the carbon gets taken up via carbon dioxide via plants and incorporated into the food chain. You can see here that the atmospheric concentration of carbon-14 from 1930 to 1950. And after 1950, you could see that the concentration of carbon-14 dramatically increased in the world. And this was due to the nuclear weapons that were used against Japan during the Second World War, which led to the high amounts of radiation and nuclear activity causing increased number of carbon-14. So what Bergman did is actually he used carbon-14 labeling to see if we do autopsies, they looked at the heart tissue and they looked at the actual cardiomyocytes to see, well, how much of the DNA in cardiomyocytes is actually made up of using C14. Because after 1950, was about 1955, there was a dramatic increase in the amount of carbon-14. So based on that and using statistical models, they were able to determine that approximately 0.5 to 1% of cardiomyocytes you renew every year. This is in adults. And within the lifetime of a person, usually approximately 40% of the myocardium or cardiomyocytes is replaced. And just to caveat, this is heavily skewed towards the younger patients. So when we're born, the ability of the cardiomyocytes to renew is 1% or even higher. But by the time we reach the age of 70, it's really even below 0.1%. So it's really skewed more towards the beginning of life, and it decreases dramatically as we get older. So my research was mostly looking at mice and trying to determine the mechanism. Most of my research would be going forward would be looking at mice and trying to determine, well, mice like adults and humans, particularly if they have a myocardial injury, they cannot regenerate and they form heart failure and usually subsequently die because of that. So we're going to be looking at cardiomyocytes. So the question we want to answer is, well, what happens with cardiomyocytes in mice after birth? So what we did was we actually took hearts. We use a collagenous enzyme, which is an enzyme which breaks down connective tissue within the heart and lets all this cardiomyocytes separate and form and essentially dissolve in a solution. And then we're able to count them individually looking at the microscope. As you can see here, there are two periods of cardiomyocytes replication that occurs in mice. So birth just means the time the mouse was born, and P just represents the day after birth. So P5 means 5 days after birth, P15 means 15 days after birth, and P300 means almost a year after birth, or 300 days after birth. And you can see there's two different time points where there's cardiomyocyte expansion. It happens in birth to 5 days after birth, and it occurs from second week of life to about third week of life. So based on this, we want to know, well, where do the cardiomyocytes come from? Because there's this whole time, this past few decades, we were looking at, well, do they come from stem cells? Because that's what we've been injecting. So I want to know, do cardiomyocytes come from stem cells, some kind of progenitor cell, or do they come from the existing cardiomyocytes, which are in the heart functioning currently, and they just divide? So for this, we used a specific genetic model where we took mice and we labeled just their cardiomyocytes in the heart with one of four colors. We either labeled them with green, yellow, red, or blue. And then we only labeled about 1%. So how does that look like? I think it will help you to see. So you could see here, this is the borders of different cells, and you could see red is a cardiomyocyte. And so we label about 1% of cardiomyocytes, and then we wanted to see, well, what happens when they divide? If it's the cardiomyocytes themselves that are dividing, what we expect to see is clusters of red cells together, because one red cardiomyocyte will give rise to a daughter cell that's also going to be red because they're going to share the same DNA. While if it's stem cells or any other type of cell that comes into the cardiomyocytes or is there but doesn't act as a cardiomyocyte, we will not see increase in color. So what do we actually see? So as you can see, So as you can see here, we went from one stem cells to now clusters of stem cells. You can see a bunch of red cells being close together. And that essentially what it tells us is there's division occurring, and division is occurring from existing cardiomyocytes. Because again, for this experiment, we only labeled the only things that express this red color is cardiomyocytes, fully functional adult cardiomyocytes. So the fact that we went from one cell individually to multiple clusters of cells tells us that the existing cardiomyocytes dividing, that at the times where at decent mice between shortly after birth and pre-adolescence, which is the second to third week of life, existing myocytes can divide, which we thought was exciting. It means even after birth, cardiomyocytes can divide, but there's some block that prevents them from dividing after a certain point. So we next want to determine, well, what causes the cardiomyocytes to replicate? Like, what's the stimulus that causes them to replicate, and can we potentially use that to determine the mechanism of cardiomyocyte proliferation and division? So for this part, we really focused on the second burst, the second wave of proliferation that occurs between P15 or 15 day after birth and P20 to P21. The reason why we chose this is because we already had some literature that shows, and some of our own findings, that shows that around the second week of life in mice, their thyroid hormone level increases fourfold. So from the time of birth to about second week of life, the concentration of thyroid hormone is relatively stable and usually and quite minimal. But after the second week of life, it increases 4 to 5-fold and maintains then a steady state for the rest of the adulthood. So our hypothesis in the lab when I first started was, could thyroid hormone potentially be responsible for this replication, at least in cardiomyocytes in mice, during the pre-adolescent period? So for this, we used an experiment where we gave thyroid hormone to mice, P2 and P3, so second and third day after birth. The reason why we chose this time frame is that we know, as I previously mentioned, is that after birth to about 14 days of life, mice have very low level of thyroid hormone. So at this point, the thyroid hormone is not really expressed. So when we give exogenous, it means we really could control how much thyroid hormone there is and to really isolate the effect of thyroid hormone on the cardiomyocytes. As you can see, the second column indicates the cardiomyocyte number in millions. And you can see the vehicle compared to the T3 group. The T3 have approximately 10% more cardiomyocytes, which was statistically significant. The other chart just shows other various factors that are associated with replication. So the first one just tells you how much DNA content was there inside the cardiomyocytes. So cardiomyocytes are one of the few cells that could actually have more than 2n number of nuclear DNA. So they could actually have 2n, 4n, or 8n, and depending. And so you can see inside B that the majority of the cells that were present were still just regular 2n in terms of content. The second group is C, looked at whether it's mononuclear or binuclear, and it was mostly actually mononuclear cell division. The bottom D and E, it just shows you different. If it shows you markings, specifically when we looked at EDU, is a thymidine analog, which is this DNA. So we want to see, is there DNA synthesis going on? So by giving mice EDU during the time of thyroid injection, if there's DNA synthesis and replication, the nuclei will be marked with a color which is usually like red to pink. And you can see within the boxes there is definitely red to pink within the nucleus, suggesting there's increased DNA synthesis. So based on all this, we were relatively confident that thyroid hormone acts as a mitogen or a growth factor for cardiomyocytes during development. So the next big hurdle was really trying to identify, well, how does thyroid hormone cause proliferation in cardiomyocytes? Because from what we know, thyroid hormone is a differentiation factor. So it usually causes cells to become differentiated into the end form, or at least the most functional form they need. But this traditional dogma was that cells that are differentiated don't divide. So this was really something we really had a lot of trouble trying to identify and find out. But I think at the end it was really worth it. So just in the interest of time, rather than going through every step how we came up with the pathway, I'll show you the pathway and then the discoveries that we made based off of that. So this is the pathway that we found based on many, many years of research. So T3 we found actually induces IGF-1, which is the insulin growth-like factor, which then activates the receptor, which then activates downstream molecules such as MEK and ERK. So in ERK, this is really going back to the biochemistry in the medical school, is a nexus for proliferative signaling. So ERK is a transcription factor which resides in the nucleus, and when it gets phosphorylated, it becomes active. And when ERK is active, it actually is able to transcribe proteins which are needed to help the cell transition through the cell cycle, things like cyclins to transition to the G1 and G2 phases of the cell cycle, and allowing the cell to undergo mitosis and DNA synthesis, or the S phase. So we found that the ERK is phosphorylated after giving T3, and ERK then is able to activate proliferation and cyclins. And ERK is actually also very crucial in preventing apoptosis within cardiomyocytes undergoing stress. So ERK has multiple beneficial pathways. So T3 activation of IGF-1 actually not only helps the cell replicate, at least when they can, and it also helps cells survive. If there is a stress, ERK phosphorylation does help cells survive as well and prevents apoptosis. So the next thing we want to do is, well, when do the cardiomyocytes lose their replicator potential in response to this thyroid hormone? Is it gradual or does it occur suddenly? So for this, we gave thyroid hormone to 3 H points. we gave it P2, which is the time point where the first proliferation of births occurs, P8, which is in the middle, and P16, which is already doing the second one. And just to help you kind of go through this chart, the A at the bottom represents, you see it says P2, then it says A and B. So this just this represents whether it's the apex we're talking about, which is here highlighted as red, or the base. And the base is just really the location here I'm showing you with my arrow, just corresponds with the base of the myocardium. So we actually just we divided the heart into these two sections to see where is there cyclins. And cyclins, is just a reminder, is the proteins that help the cell transition through the cell cycle. So if cells are actively dividing, or they will have cyclin expression in them. So when we give thyroid hormone to P2 mice, in the apex and in the base, there's increased cyclin concentration in both, which coincides again with cell replication, as we saw before, that during that P2 time, there is replication in cardiomyocytes in the neonatal mice. So interesting, what we found is that P8, giving thyroid hormone, the apex of the heart, which is the bottommost part of the heart, had definitely a robust increase in cell cyclins, which corresponds to increase in cell cycle proliferation. But when we looked at the base, now you have a blunting of the proliferative signaling, or the cyclin expression. And when we give it at P16, we don't have any more cyclin expression. So by P16, the heart cardiomyocytes lose their ability to replicate, or at least to replicate to the stimulus from the thyroid hormone. So based on this, we wanted to determine, well, what exactly causes this, right? So I just want to bring back the diagram I showed you here. So what we did is actually we tested, we knew the mechanism already. So what we actually looked is compared mice hearts at P2 and to P16 and see what is different when we give thyroid hormone. So we measured the level of IGF-1. It was the same between P2 and P16. We measured the level of MEC. We measured the level of ERK in the cytoplasm versus the nucleus, and it was the same. But then when we looked at the phosphated ERK levels in the nucleus of P2 hearts, or second day after birth, and compared it to the phosphated ERK levels in the P16 hearts, they are very different. So from that, this kind of clued us in that something is happening to this ERK once it's phosphorylated in the nucleus, or the active form, that prevents it from being able to cause the proliferative signaling. So since we knew the target, we looked at which genes could potentially dephosphorylate or deactivate the ERK, and we found that this DUSP5, which is dual specificity protein phosphatase 5, actually resides in the nucleus, in cardiomyocytes, and it's actually very specific for ERK. So when T3 activates this pathway and phosphorylates ERK, and ERK goes to the nucleus to be able to cause proliferation, by P16, the mice have DUSP5, which comes in, dephosphorylates it, and prevents ERK from being active. Hence, it stops cardiomyocytes from being able to divide. So this was our hypothesis. From this, we wanted to test, so what happens if we get rid of this DUSP5? Can we potentially allow adult cardiomyocytes to divide again? So for this experiment, we gave siRNA, which is essentially a technique which helps get rid of or completely eliminate expression of a particular protein. So in this case, we gave siRNA specifically for DUSP5. So as you can see the chart here, we completely get rid of DUSP5 at P37, or about 5 to 6 week old mice. So which is again the time point where cardiomyocytes can't divide anymore in mice. This is the time point where if they have a heart attack, the cardiomyocytes die without any really significant replicative capabilities. So we gave this siRNA and we inhibited USP5. Then we gave 5 days of thyroid hormone, trying to see, well, if we give exogenous thyroid hormone and increase the concentration, can we get the cardiomyocytes to divide? So here we have scramble, which is just really a control group. And here we have the DUSP5 siRNA, which inhibits the DUSP5 expression. And we found the mice that got the T3, indicated here by red, they had an increased cardiomyocyte number by approximately 50%, which was highly significant. And really for us, really encouraging, because this is one of the first therapies that we could see which actually increased the cardiomyocyte number, and specifically adult cardiomyocytes. And here we further want to show you the DUSP5, the heart to body weight ratio. And here you could see that in the mice that got DUSP5 siRNA, that inhibits, again, the expression of this protein, the heart to body weight ratio increased, suggesting there's increased actually myocardium. Here, I just want to show you the representation of the M mode on the echoes. Looking at the top one is the GSP5 plus vehicle, so they did not get the T3, which is needed as a mitogen or at least as a growth factor. And the bottom one is looking at the GSP5 siRNA plus the T3. And you can see there's increased fractional shortening compared to the two. And to the right, we actually quantified the ejection fraction based on that. And we found it to be a 25% increase in the fractional shortening in the mice that were treated. So how do the actual echoes look like? So we actually have, these were healthy mice. These mice didn't have any type of cardiomyopathy or ischemia. This is the vehicle plus thyroid hormones. So these mice, the GSP5 was still present in their cells. So when we give thyroid hormone, you can see the function is right here. All the walls are moving together. And again, just a mouse's heart beats about 500 to 600 beats a minute. So this is very slowed down for comparison, just because there is marked differences between humans and mice cardiomyocytes. And here again, you could see all the walls are moving together in, and you could see the ejection fraction. It looks relatively normal. So now let me show you what happens when we give the GSP5 and the thyroid hormone. I think the most obvious and striking thing is you can see how thick the myocardium becomes. And also look at the ejection fraction now. It definitely looks like the walls are coming closer together. And the last thing is I want you to pay attention to is that the end-diastolic volume, at least the end-diastolic volume in the left ventricle, is actually pretty much maintained between these two images. And taking that with the fact that the cardiac weight increases, we actually believe that there was cardiomyocytes division occurring and actually increasing the contractility. And the other thing was, if you think about it, this is like a therapy which could improve the cardiac function from baseline, which it hasn't really ever been shown with any trial or any data, which we thought was very exciting. So when is GSP5 expressed and what regulates GSP5 was our next question that we wanted to know. Is like what happens at P16 that the cardiomyocytes lose the ability to divide, and what causes the expression of GSP5? So we looked at the tissues. Again, we took the apex, which is again here, and the base, and we used Western blots to see, well, when is GSP5 expressed, right? So we found that at P7, the apex has no GSP5, but the base does have, and that trend continues from P7 to P13, where you could see that the apex does not have any GSP5, but the base has increasing number or increasing concentration of GSP5 within the cardiomyocytes. And by P14, both the apex and the base both now have GSP5. And this again coincides with the time that the cardiomyocytes no longer divide when giving thyroid hormone. So whatever it's causing GSP5 expression, it starts at the base and it moves down to the apex, as we can see here. So based from this, our next thought was, well, what happens in the heart that starts at the base and then extends to the apex around the second week of life? So one of the things we want to try is, could it be the sympathetic nervous system, right? So here you can see the red lines indicate the sympathetic nervous system. They go to the base of the heart, the base of the LV and the RV, and then it extends down to the apex. So our hypothesis was, is it possible that as the heart gets sympathetically innervated, could that be inducing the GSP5, and which actually leads to the loss of cardiomyocyte replicative capability? So here TH stands for tyrosine hydroxylase, and this is a precursor to norepinephrine and epinephrine, which is what the sympathetic nervous system uses to divide. And you can see that when the GSP5 expression first starts becoming apparent, that's when the tyrosine hydroxylase starts appearing as well, which suggested to us that there's a correlation. This doesn't prove causation, but it suggests a correlation between when tyrosine hydroxylase is present and when GSP5 is expressed. So our proposed mechanism now for what causes the cardiomyocytes to lose the ability to replicate is that we have the sympathetic nervous system releasing norepinephrine or epinephrine. It activates the beta-1 adrenergic receptor, which then induces GSP5 and prevents ERK from being phosphorylated, which essentially prevents the ERK from being able to transcribe or translate proteins which help the cell progress through the cell cycle. And also, again, ERK phosphorate also helps prevent apoptosis. So again, if you inhibit or phosphorate ERK, you increase the chance of cardiomyocytes undergoing apoptosis during times of stress. So how do we test this? We actually gave the mice metoprolol XL once a day injections, and the thought is, well, if the beta blocker receptor is what causes GSP5 expression, maybe by giving metoprolol, we could decrease the expression of GSP5. So here we gave metoprolol over the course of 2 weeks, and then we measured the amount of GSP5. So you can see the baseline level of GSP5 is labeled right here in this 1. And then we compared the levels after 2 days, 4 days, and 14 days of giving beta blockers. And you could see the level of GSP5 markedly drops after 14 days of therapy. And then this +2 represents what happens when we stop therapy. So after 14 days, therapy was stopped. And then you could see within 7 days, the GSP5 levels go back to normal. So further now shown there's a causation, this shows that there's a that beta blockade. If you beta blockade, if you give beta blockers and block the beta 1 adrenergic receptor, you actually decrease the expression of GSP5, which shows causation. So what we've shown so far, just kind of like a summary, is that reversing the cardiomyocyte cell cycle block, which is the GSP5, enables the cardiomyocytes to enter the cell cycle. And then with combination of T3, which we use as a mitogen or something to promote the cardiomyocytes promotes cardiomyocytes to enter the cell cycle, we can actually improve the LV mass, we can improve the ejection fraction while maintaining the end diastolic volume. So the last year of research, which is why I took a third year to do research, was actually trying to see, well, how does it work in ischemic heart models? Because at the end of the day, we're not trying to take a healthy heart and give it more LV mass, because the clinical implication of that could be multiple. But what we really wanted to see is, well, what happens when we give to the hearts which are struggling from heart failure? So for this, we took 6-week-old mice, which consider adults, and I performed the LED ligation at 7 weeks. After 7 weeks, after the ligation of the LED or MI, essentially like an MI that they had, we left them for 2 weeks for the scar and the fibrosis to form, and for the mice to develop heart failure. So we were trying to mimic more of a stable ischemic disease with heart failure development. And after the 2 weeks, we started them on beta blockers, and we gave the beta blockers for 2 weeks. Again, the reason why we chose 2 weeks, as I showed you previously, that's when the lowest level of GSP5 was expressed after 2 consecutive weeks of giving metoprolol or giving a beta 1 specific beta blocker. Then we gave either mice T3, which is the mitogen, which I've previously shown, versus vehicle for 5 days. So it's only a 5-day burst. And then we waited for 4 weeks, and then we repeated echocardiogram to see what happens to the ejection fraction and the wall thickness after therapy. So you can see here, pre-treatment or pre-surgery, the ejection fraction was between 55 and 70%, and it was similar between both groups. After the MI, the ejection fraction dropped between 15 to 30, which was like inclusion criteria for our study. So we only took mice with an EF between 15 and 30. And then after therapy, you can see there's a marked difference in the ejection fraction between the MI therapy, MI plus therapy with T3 and beta blocker versus which is right here, which is just beta blocker for 2 weeks itself, which essentially had no improvement. And interestingly, when we looked at the histological analysis, there was still scar at the area of the LED territory when we sectioned them, but there was actually more cardiomyocytes around the edges, which we're currently evaluating, but which gave us the assumption, or these gave us the hint that what actually is happening, the existing myocardium within the other distributions is actually able to replicate and kind of help surround some of the scar and improve the contractility within the area of infarct. So I think for the future, what we're currently trying to do right now is to evaluate what does GSP5 do in humans? Because if the mechanism is similar in human adults as is to mice adults, then potentially using GSP5 inhibition with thyroid hormone, these short bursts of thyroid hormone, could potentially provide a reasonably easily translatable approach to rebuilding heart muscle. So which is we're currently working on now. So I want to thank you for your time and for listening to my talk. I hope you guys were able to kind of stick with me through the more basic science aspect of it. A lot of this I couldn't have done without my PIs, Nawaz Nakwi and Hassan Hussain, and my co-fellow Lynn Tan, and our collaborators at Australia and John Calvert and David Martin in Oakland. Thank you very much for your time. And if you have any questions, I'd be glad to answer them.
Oh, Nikolay, that was good. You're right. It was a very comprehensive review of your research. I mean, I guess my question as a clinician, I mean, with what you've learned through this process, did it have any impact sort of on what you thought maybe, in terms of translatable things that you, like I said, that you could have apply to your clinical care in terms of heart failure, that sort of thing?
Yeah, so I mean, ultimately, this is what we're trying to do is to apply to that. So what the current obstacle is trying to see is the mechanism for cardiomyocytes. So from the study I showed you with looking at the carbon-14, we know adult cardiomyocytes could divide, in humans even. So there is some limited ability to divide. The question is, how can we enhance that innate ability to divide? And if, again, this is an if, which because we have not done these trials in humans, if humans also have GSP5 in their nucleus, and that's what causes the loss of them to enter the cell cycle, reversing that potentially with beta blocker. And then the thing is, so there's two things. One is a brake, the other one is the accelerator, right? To move a car. So we looked at the GSP5 as a brake. So if you have a brake on and you press the accelerator, car's not moving anywhere. But if you let go of the brake, but you don't press the accelerator, again, the car's not going to go anywhere. The same thing with cardiomyocytes. So by removing the brake, which is a GSP5, and then giving a thyroid hormone, which works as a mitogen, what these helps induce insulin-like growth factors in cardiomyocytes in mice, it's like the accelerator. It allows the cell to enter the cell cycle, and it allows the cell to make insulin-like growth factors and other factors that allow it to divide. So by potentially combining both those things, if we get the endogenous, or these the cardiomyocytes which are still left after MI or whatever injury, they start dividing, that could actually help translate to actually improving cardiac function potentially, like we showed with healthy mice. There are some obviously clinical considerations to make. One, these are sick hearts, and giving thyroid hormone could potentially cause arrhythmias. The benefit, some of the things which you notice which are encouraging is that in mice, when we gave, these mice had pretty sick hearts. Their EFs were 20 to 30%, some were like 10 to 15%. And giving them thyroid, none of the mice died after they were randomized. So the thyroid didn't seem to cause increased mortality in mice. But there's obviously going to need to be a lot of research done to see what would happen when we give thyroid hormone to humans. And practically speaking, how much, if you might wonder, how much thyroid hormone were you giving? So we gave enough thyroid hormone to essentially double their circulating thyroid hormone level. So in mice, the usual level is about 2 picomolar. We increased it to 4. That was only for 5 days, and then they went back to normal. And we looked at various fun things like body weight, hair loss, temperature. None of those things actually changed between thyroid hormone treatment and normal just placebo. So we think this is just extrapolation, but we think the thyroid should be relatively safe. And once we could do research in humans to see if there's GSP5, I think it would be very easy potentially to do a trial, which we're currently working on, to give patients beta blocker and give them thyroid to see, give them slightly higher level of thyroid to induce the cardiomyocytes to divide and see, is there improvement in ejection fraction? Is there improvement in the contractility, and also potentially just functional status of the patients?
Very interesting. I think Dr. Smith has a comment.
Nick, I enjoyed it. Just some comments related to your first comments about medicines just putting a Band-Aid on things. So there are situations where severe left ventricular dysfunction is reversible. And the medicines that do that are the beta blockers in patients with non-ischemic cardiomyopathy who do not have large areas of scar. So just remember the beta blockers do cause reverse remodeling and can have a dramatic effect in some people. And then the other one is when there's left bundle branch block with a Q respiration more than 150, that we see super responders to cardiac resynchronization. A third one would be patients with end-stage renal disease who have non-dilated ventricles but severely depressed ejection fractions. They often normalize after kidney transplantation. So just I think when we think about things, we need to think about, is there dead meat there that's never going to get better? Are there myocytes there that just aren't functioning properly, and how do we get them to function properly? And I think there can be clues from that sometimes with the EKG. If there's very bizarre EKG, you'd suspect there's a lot of fibrosis. If you have just a relatively normal QRS and a non-dilated ventricle. So just let's keep working on the work that you're doing. About every few years, there's a dramatic study that comes out or case reports of regeneration, and we spend a lot of time with patients talking about these things, which currently are hype, but I think there is a lot of hope with the type of work that you're doing. But just had to comment on what does work.
Yeah. Oh, and the other thing is I want to mention is that one of the things we thought about, could this beta-1 interaction with USP5 be also what potentially could help, why beta blockers help in heart failure? Because as I mentioned, if you have higher levels of ERK, which is phosphorylated, it actually prevents apoptosis and cardiomyocytes. It's cardioprotective. So regardless of what kind of cardiomyopathy you have, if you have a lot of stretch and cardiomyocytes undergoing stress, having higher levels of ERK phos does help. So potentially some of the benefit could be not from just a preload perspective and decreasing the sympathetic tone, or I guess a preload and afterload perspective of beta blockers. It could also be the effect of GUSP5 potentially, which obviously needs to be further evaluated. But I thought it was an interesting, especially from the cardiology perspective, which was why I wanted to talk about the interaction between the beta-1 receptor and the GUSP5 induction.
And Nikolay, this is Mohan Jokadar. That was fascinating. While listening to your talk, I couldn't help but be reminded of the axolotl. The axolotl is a type of salamander. It's the champion of regeneration in the animal kingdom. It's a salamander that lives in Mexico, I think. And what's interesting about that, and obviously my knowledge in basic science is cursory, is that when they do have a limb that is severed or a spinal cord that is severed or damage to the heart, they regenerate first by inhibiting fibrosis and scar formation. And then stem cells, regenerative cells, are recruited to that area. What is also fascinating about the axolotl is their response to thyroid hormone. So they remain in the larval fish stage, tadpole stage, unless they're giving thyroid hormone, depending on temperature change. And then with thyroid hormone, they turn into the adult, sexually mature form. So I wonder if we can learn, I'm sure you folks have already done this, look at gene expression of ERK and DUSP5 and other gene expressions in this champion of regeneration as it applies to mammals and humans.
I mean, that's excellent point. We haven't done it with that particular animal. I know a lot of researchers use zebrafish because zebrafish like have the complete potential to regenerate the heart. So a lot of work is being done looking at that mechanism. I think where we are right now, we want to see what actually happens in humans, because there is a lot of samples. For example, patients who want to go transplant, cardiac transplant, their hearts are taken out. So looking at those samples, actually looking at various expressions of GUSP5 and all those things, I think is the next step, because at the end of the day, we wanted to make this applicable to humans. And you looking at other animal models could give us, obviously, gives very valuable information. But I think at the end of the day, what's been missing for a very long time, Dr. Smith alluded to, is that there's a lot of hype, but not really enough application to human trials data, actually showing human improvements. So I think right now a lot of labs are moving to animal models, which are more similar related to humans, because that's what ultimately we want to move to, or just to have a therapy which will help with human regeneration. So Nikolay, I think right now pigs are being used a lot, mice are being used a lot, or any animal which has a very similar physiological characteristics to human hearts.
Nikolay, why don't we finish up with a question from Elena? She mentions that your mice are 5 to 7 weeks, which is adult, but young adults. Would you expect a different response to the stimulation in older mice, like we see less myocyte division in older humans?
Yeah, that's an excellent question. I think the answer is yes. So I've tried to do some experimentations with 6-month-old mice. The problem is when you take a healthy heart and you ligate the LAD, the mortality rate is very high. So most of the mice don't survive the 2 weeks. So when I showed you this experiment, Yeah, when I showed you this experiment with the MI, within just 2 weeks before we started any therapy, the death rate was about like 50%, 50 to 60%. And these were young adult mice. So as you can imagine, 6-month-old mice, which obviously the older you get, the higher your risk for everything, their mortality rates were just excessively high and cost prohibitive to actually work with. So, and we know as I showed you at the carbon-14 dating, that the cardiomyocyte replication drops as we get older. So and so to the point that it's true that the older you are, the less replication you have, so it would become less effective. But the cardiomyocytes still do replicate, because when we looked at, we didn't do MIs in them, but when we gave them thyroid hormone to the 6-month-old mice, there was cardiomyocyte replication.
Well, like I said, thank you again, Nikolay. Fantastic review and some interesting new concepts. So thank you, everybody, and we'll see you next Friday.
The preceding program is copyrighted by Emory University.